I'm about to tell something that could save a life, and it has to do with a vitamin almost every senior has been told is totally safe. Vitamin D. I'm Dr. Claire Whitmore. After more than 20 years as a cardiologist, I've seen the inside of thousands of arteries and read countless scans and lab reports from seniors whose hearts, brains, and kidneys were silently damaged by something nobody suspected: too much vitamin D taken for too long, without the right blood tests first. The same vitamin that can protect bones and possibly immunity can, in the wrong doses and circumstances, calcify arteries, injure kidneys, and destabilize heart rhythm. By the time this is finished, seniors will know three things very clearly. First, what blood level of vitamin D is actually safe for older adults. Second, which simple blood tests must be done before another high-dose pill is swallowed. Third, a step-by-step way to correct low vitamin D without sliding into toxic calcium, kidney failure, or arrhythmias. The key message is this: vitamin D is not a harmless candy. It is a hormone. And for seniors, it is very easy to cross the line from helpful to harmful if one thing is not done first: measure the level and check kidneys and calcium. To see what happens when that step is skipped, think about Eleanor. Eleanor was 79, a retired librarian, widowed, living alone but proud of her independence. She used a cane outside, cooked simple meals, and spent afternoons reading by a sunny window. Her chart looked like many seniors: blood pressure around 136/80 on a small dose of lisinopril, cholesterol controlled with a statin, mild kidney disease with a creatinine of 1.3, and an estimated GFR around 48, and osteopenia on a bone scan but no major fractures. Years ago, she had been told to take a calcium tablet with vitamin D, 600 milligrams of calcium plus 400 IU of vitamin D twice daily. Then the pandemic hit. Articles and friends everywhere started talking about vitamin D for immunity, for cancer prevention, for mood. At church calls and over the phone she heard, "Vitamin D is the miracle vitamin. Seniors just can't get enough." In January, her neighbour Margaret showed her a large bottle she had ordered online. Vitamin D3, 10,000 IU per capsule, labelled high potency, immune and bone support. "Look, Eleanor," Margaret said, "all the blogs say seniors should be on at least this much. Doctors are too cautious, it's natural. How could it hurt?" Eleanor took the bottle with her to her next appointment. "Doctor, I'm thinking of taking one of these every morning," she said. 10,000 units. It says it helps bones and immunity. Her doctor glanced quickly at the label. "Vitamin D toxicity is rare," he said. "For a while that dose should be fine, especially with thin bones. Seniors are often low. Just don't go overboard." "Should levels be checked first?" Eleanor asked. "We checked yours a few years ago," he answered. "It was a bit low, around 22. Taking more will probably help. There's a wide safety margin." And that was it. No new order for a 25 hydroxyvitamin D level. No calcium check. No careful look at how her mildly reduced kidney function should change the plan. Eleanor went home and, starting in February, added one 10,000 IU vitamin D3 capsule every morning to her routine, on top of her existing calcium with 400 IU twice a day. Her total intake jumped to around 10,800 IU of vitamin D and 1,200 milligrams of calcium daily. After 2 months, she felt all right, maybe a bit more energetic. Friends were enthusiastic. "Vitamin D is amazing," they said. "My cousin takes 20,000 IU. It's safe, it's just a vitamin." After 6 months, at a quick blood pressure check, basic labs showed a calcium of 10.4 mg DL, high normal, and a creatinine of 1.4, slightly worse than before. "Looks fine," her doctor said. "Numbers bounce around. Keep up the vitamin D, it will help bones." She felt reassured. She ordered another big bottle on Subscribe and Save. By month 8, small warning signs crept in. Constipation worsened. She blamed diet and took more laxatives. A dull nausea showed up many mornings after pills. She assumed it was her statin. Thirst increased. She woke at night to urinate more often. She mentioned these in pieces. "I'm a bit more tired. I'm so thirsty lately," but no one put them together. Then confusion and fatigue entered. She mislaid objects more often and felt foggy. Her daughter worried about early dementia. One December morning, everything broke. Eleanor's daughter called around 9 a.m. Eleanor answered, voice weak. "Mum, are seniors okay?" her daughter asked. "I just feel so tired," Eleanor said. "My head is heavy. Legs don't want to move." Her daughter offered to come over. Eleanor said, "Maybe later, I'll rest." By 10:30, Eleanor tried to stand and go to the kitchen. She became dizzy, grabbed the counter, spilled water, and slowly sank to the floor, overwhelmingly weak. When her daughter called again and got no response, she drove over, used her key, and found her mother on the kitchen tiles, awake but barely responsive, skin dry, lips cracked. In the emergency department, vital signs showed elevated blood pressure and heart rate. Labs told the real story. Calcium 13.2 mg DL, dangerously high. Creatinine 2.2 mg DL, a big jump from baseline. BUN 45 mg DL, 25 hydroxyvitamin D level, 118 ng/ml in the toxic range. An EKG showed a shortened QT interval and extra beats, heart rhythm changes typical of severe hypercalcemia. The admitting physician looked at her medication and supplement list. Vitamin D3 10,000 IU daily for about 10 months, he said quietly, plus calcium. This is hypercalcemia from vitamin D toxicity. Eleanor was moved to the intensive care unit. She received intravenous fluids to flush out calcium, medications to lower it, and all vitamin D and calcium were stopped immediately. Her kidneys, already fragile, had taken a hit. After days, creatinine settled around 2.0, far worse than her original 1.3. Her heart continued to throw irregular beats. Her thinking remained cloudy at times. She left the hospital alive, but with stage 4 chronic kidney disease, a complicated medication list, strict diet and fluid rules, and lost independence. 6 months later, with worsening kidney function and recurring arrhythmias, she faced discussions about dialysis, something she never imagined when she started that safe, natural vitamin. What changed her course was not some rare poisoning. It was long-term, high-dose vitamin D taken without doing one thing first, checking vitamin D level, kidney function and calcium, then adjusting dose based on those results. Now, why did this happen? Vitamin D works more like a hormone than a regular vitamin. It helps the body absorb calcium and phosphorus from food, supports bone mineralization, and influences muscles, the immune system, and even the heart. It is also fat-soluble, which means it is stored in body fat and released slowly over time. In moderate doses, vitamin D can correct deficiency and help maintain bone health. But when levels are pushed too high for too long, the body absorbs too much calcium and starts depositing it in the wrong places: kidneys, blood vessel walls, heart valves, and soft tissues. At the same time, kidneys, especially aging, slightly damaged kidneys, struggle to dump out the extra calcium and vitamin D. Seniors have several vulnerabilities that younger adults do not. Kidney function declines with age. Even mild chronic kidney disease, like an estimated GFR of 45/60, means the safety margin for vitamin D is narrower. The kidneys help activate vitamin D and excrete calcium. When those kidneys are already tired, adding big doses of vitamin D and extra calcium can overload the system. Arteries and heart valves in seniors are more prone to calcification. Years of blood pressure, cholesterol, and inflammation have already laid down some calcium. High vitamin D plus high calcium can accelerate that process, turning flexible arteries into stiff pipes, raising blood pressure and heart strain. Multiple medications complicate things. Thiazide diuretics, water pills like hydrochlorothiazide, raise blood calcium levels. Digoxin, a heart medication, becomes more dangerous when calcium is high. Even some over-the-counter antacids add extra calcium. A dose of vitamin D that might look safe by itself can become risky. Combined with these, finally, metabolism and clearance slow down. Seniors often have higher body fat percentages and slower liver and kidney clearance. That means vitamin D builds up more and is cleared more slowly. 10,000 IU a day in a 30-year-old for a short burst is not the same as 10,000 IU a day in a 79-year-old with reduced kidney function for 10 months. For years, messaging about vitamin D has swung between extremes. At one point, many physicians underplayed it. Take a multivitamin, get some sun, you're fine. Then came a wave of enthusiasm. Everyone is deficient. Take 5,000 or 10,000 IU a day. Toxicity is rare. Newer research has forced a more nuanced view. Large trials like VITAL, which gave 2,000 IU daily to tens of thousands of adults, did not show dramatic reductions in heart attacks or cancers from blanket supplementation. Other studies in JAMA found that very high intermittent doses like 500,000 IU once a year, given to older women, were associated with more falls and fractures, not fewer. Observational data show a U-shaped curve. Seniors with very low vitamin D levels, below about 20 Ning-Lis, have more fractures and possibly more illness, but those with very high levels, above roughly 50-60, also may have higher mortality and more falls. The safer middle ground for most older adults appears to be a 25-hydroxy vitamin D blood level in the range of about 30 to 50 ng. Below 20 is usually considered deficient. Between 20 and 30 is often called insufficient. Above 50-60, especially above 70, is where potential risks often begin to outweigh any benefits. Notice what is central here: blood level, not just pill dose. The same dose of vitamin D can yield very different levels in different seniors depending on absorption, weight, kidney function, and other factors. So when is vitamin D toxic for seniors? It becomes toxic when high doses are taken for months without checking levels. Calcium and other drugs that raise calcium are piled on top. Early warning signs: thirst, constipation, nausea, confusion, irregular heartbeat are dismissed as just aging. Baseline kidney function is not taken into account. The one thing that must be done first before continuing or increasing vitamin D in a senior is simple but non-negotiable: get the right blood tests. For any older adult taking more than about 1,000–2,000 IU daily for longer than a couple of months, or any senior with kidney disease, heart disease, or a large supplement list, that means checking at least 25-hydroxy vitamin D. This is the right test for vitamin D stores. Serum calcium, creatinine and estimated GFR, kidney function, sometimes parathyroid hormone PTH is also checked, especially if bones or calcium look abnormal. Those numbers let doctors and seniors answer crucial questions. Is there true deficiency to correct, or has the needle already swung into high normal or elevated territory? Is calcium creeping up toward the upper limit of normal? Are the kidneys strong enough to handle a higher dose? Once those answers are in hand, dose decisions can be made sensibly. If vitamin D level is under 20 ng deficient, many clinicians will use higher doses in the short term, such as 50,000 IU weekly for 6–8 weeks, or 4,000–6,000 IU daily for a limited period, then recheck levels and drop to a more modest maintenance dose, often 1,000–2,000 IU daily. In seniors with kidney disease, repletion regimens are often gentler and monitored more closely. If the level is between 20 and 30 ng/m, daily doses around 1,000–2,000 IU are usually enough to bring levels into the 30s or low 40s over a few months. If the level is already between 30 and 50 ng/m, target range, many older adults do well on 800–1,000 IU daily for maintenance, or even less if they get some sun and dairy intake. Blanket 5,000 or 10,000 IU doses are usually unnecessary here. If the level is above 50–60 ng/ml, especially with high normal or elevated calcium, the safest move is often to reduce or even hold supplementation for a time, especially the higher doses, and repeat labs after a few months. There is no good evidence that pushing levels higher than that benefits seniors. There is real concern it may harm. Calcium intake must be considered at the same time. Many seniors do not need more than about 1,000–1,200 milligrams of calcium per day from food plus supplements. Those with kidney disease or vascular calcification may need less. Calcium supplements should be reviewed and sometimes reduced when vitamin D doses are high. Medication interactions are crucial. A senior taking vitamin D, a calcium supplement, a thiazide diuretic, digoxin, with any degree of kidney disease should be having regular checks of calcium, kidney function, and vitamin D level. That combination is potent. Symptoms of vitamin D-related high calcium should not be ignored. Warning signs include mind constant thirst and frequent urination, nausea, vomiting, or loss of appetite, constipation that is out of proportion to diet, deep fatigue or muscle weakness, confusion, fogginess, or personality changes, new heart palpitations or irregular pulse. Any senior on vitamin D who experiences several of these should stop discretionary high-dose over-the-counter vitamin D and seek prompt evaluation. Lab work is essential. To see what happens when this process is followed correctly, think about George. George was 75, a retired bus driver. He had high blood pressure, mild kidney disease with a GFR in the mid-50s, and a wrist fracture in his 60s. After hearing friends rave about vitamin D, he started taking 5,000 IU daily 2 years earlier. He also took a multivitamin with 1,000 IU and a calcium tablet with 800 IU of vitamin D. Total daily vitamin D, about 6,800 IU, for 2 years. No one had ever checked his level. At a routine visit with a new primary care doctor, she looked carefully at his supplement list and asked, "How long have you been taking this 5,000 IU?" When he answered, "A couple of years. Vitamin D is safe," she ordered labs. His 25-hydroxy vitamin D came back at 64 N-glycemyl L. Calcium was 10.6 mg DL high normal. Creatinine was 1.5, a little worse than before. "George," she said, "your vitamin D level is higher than we want and calcium is edging up. This may be straining the kidneys. We should dial this back." Together they created a new plan. Stop the separate 5,000 IU pill, drop the calcium supplement, his diet already had plenty of calcium, and keep just a 1,000 IU daily vitamin D tablet plus his multivitamin. Total intake dropped to about 2,000 IU a day. 3 months later, repeat labs showed vitamin D at 42, calcium at 9.6, creatinine back to 1.3. He had fewer vague aches and felt less heavy. A year later, levels remained in the 30s, 40s, and his kidneys held steady. The difference between Eleanor and George was not that one took vitamin D and the other did not. Both did. The difference was that one escalated dose without ever doing the simple step first, testing, and the other had a doctor who insisted on seeing the numbers and adjusted accordingly. Seniors listening now have the advantage of that knowledge. The key points are these. Vitamin D is a powerful hormone, not a harmless sweet. For most older adults, the safest blood range is around 30-50 Nigli. Pushing levels above 50-60 brings no proven extra benefit and may increase risk. Before starting or continuing anything above modest doses, seniors should have vitamin D, calcium, and kidney function checked. Anyone already taking 2,000-5,000 IU daily or more without ever having had a level drawn should not simply continue on faith. The sensible path is straightforward. Gather every bottle that contains vitamin D, standalone pills, multivitamins, calcium D combinations, bone health and immune support products. Add up the approximate daily intake, make an appointment, bring the list. Ask for blood tests, 25-hydroxy vitamin D, calcium, and kidney function. Then, with those results, have a direct conversation. What target range is right for someone my age and with my kidneys and heart? How much vitamin D should I really take? Do we need to adjust calcium? Do any of my meds change the risk? That simple sequence, inventory, test, adjust, is what do this first really means. The tragedy in stories like Eleanor's is not that vitamin D is inherently dangerous. The tragedy is what happens when seniors are told, more is better, toxicity is rare, no need to test. The truth is, more is better only up to a point. Toxicity is uncommon but very real in older adults on high doses, and testing is cheap insurance. The vitamin D bottles in the cabinet are not going away. They can be tools, not traps, if used with respect for the numbers. Disclaimer: the content in this script is for educational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of a physician regarding any medical condition. Never start, stop, or change any medication or supplement dosage, including vitamin D and calcium, without consulting a doctor.